Thank you for the opportunity to speak once again, and really it's going to be about the mistakes I've made on the scabies part, so hopefully you won't have to make the same mistakes. So just getting things set up. Okay, issues with scabies diagnosis. I think I foolishly believed that scabies was unimportant and easy to make the diagnosis, and I could just leave it to the clinicians and not really worry about the definition because the clinicians would know. I'm more of a spreadsheet kind of guy, so I stand a bit back from the clinical side of things, but pretty early on I realised actually I have to take an interest in what the clinicians are actually thinking in terms of what is scabies and what's not. So I'll just try and quickly tell you a little bit about the story, and we'll talk about some of the things that I've learned along the way. So this is the first study that I did back in, I think, 2018, and there was a childcare centre in the heart of Ottawa, which is a big Pacific community in South Auckland. If you don't know, Auckland is one of the biggest Pacific cities anywhere. It has a very large Pacific population. Ottawa is kind of the heart of it. And the teachers were very concerned about these sorts of skin sores that they were seeing in the kids. And so I thought, I can stand back. I don't care what they think is scabies. I'm just going to ask a nurse and a GP and a dermatologist who's going to provide all the information on exactly what's scabies. And all the expertise I had was having had scabies about 7 or 8 times. Generally, I think, picking it up from hospital work that I did before I went into public health. And all I knew was that when I got scabies myself, the biggest marker of the diagnosis was when both my wife and myself were itchy. If one of us were itchy, it wasn't quite clear whether it was something else, maybe insect bites or something, but if there were 2 or 3 of us in the family that were all itchy, it was pretty clear it was scabies, and I'd treat the whole family with permethrin and later ivermectin, and we would get better. And often I'd turn up to the GP and show my daughter with her issues, with her skin sores, and the GP would say, oh, this is insect bites. And I'd say, well, actually, it could be insect bites, but actually I want some ivermectin because I think it's scabies. So the first learning really was that there was very little agreement between the diagnosis of the different clinicians. So the nurse, the outer rectangle represents all the kids that were seen in common. The green rectangle represents those that the nurse thought were scabies, and then the GP is the red. Me labelling some of them based on the latest criteria was a larger group, and the dermatologist actually surprisingly said none of them had scabies. And when I asked him, what were you looking for? He said, I was looking for mites. So that's the delta wing sign, which if you know about it, you only see it with a dermoscope. It's very small, microscopic little triangle, coffee-coloured triangle. And either that or burrows. And if you didn't see that, it was not scabies. So I know there's quite a few paediatricians in the room, so any thoughts on what might be the diagnosis here? These kids have been treated with steroids, topical steroids, and I've actually got iatrogenic Cushing syndrome from being treated with steroids for eczema, what was thought to be eczema, which was actually scabies, and some of them developed crusted scabies from steroid treatment. And we've found that steroid treatment in the case of scabies is very common in Auckland. So this is where those photos came from. So that can be a little...
What is Cushing syndrome?
Cushing syndrome is excess body fat that occurs if kids have had too much steroid. So some conditions in medicine are treated with steroids, and adults sometimes get that very sort of chubby features, buffalo hump at the back. So it can happen that if you treat with steroid, the baby actually is affected with this condition of excess steroid. And confusingly, sometimes topical steroid can actually improve scabies temporarily and make the diagnosis even more difficult, and it's called scabies incognito. Often they get a generalised eczema. There's also atypical presentations, so crusted scabies, for example. So I think it's very important, and hopefully Lucia will talk a little bit about this, is that we think about the definition of what we're calling scabies. And the Australian group, we've learned a lot from there in terms of how to accurately diagnose scabies. So my thoughts on the diagnosis, this is, in a nutshell, this is the old style where we're looking for these small, what we call delta wing signs using dermoscope. And that's great. If you see them, you know 100% it's scabies. It's very specific. But as Lucia said, it's not particularly practical in the Pacific and for field work. And also it's not sensitive. So with diagnosis, there's a trade-off between sensitivity and specificity. I used to learn a lot from a forensic pathologist who used to say it's better to be working with a living proposition than a dead certainty. So sometimes you have to trade off specificity for sensitivity. And so our first study, I showed the photos of the sores to a paediatrician in Melbourne who works with Lucia a lot, and his comment was, burrows are very rare, particularly in areas where there's a lot of impetigo and secondary infection. The absence of burrows does not preclude a diagnosis of scabies. I just came back from the Solomons, saw 200 kids with scabies, didn't see one burrow, not one mite. So that got me thinking, we really need to think about the diagnosis a bit more. And for those who haven't met Dan, he's done a lot of really excellent work in the Pacific, thinking hard about the diagnosis. He's a general paediatrician based in Melbourne, and there's a paper that he's written with a lot of dermatology colleagues, other people interested in scabies, trying to get agreement on the diagnosis and what they call a Delphi process. So the big picture really is that what we're looking for is papules, so small, itchy, raised lumps. Often you can feel them better than you can see them. That picture in A with particularly a typical distribution, so hands, feet, abdomen. You also see a more generalised, it happens in babies, it tends to be more generalised. Sometimes it can mimic other conditions like chicken pox, almost look like vesicles. Obviously the complications of bacterial infection. These are some of the signs that the clinical signs that we've been seeing in Auckland. Often papules with scaly kind of appearance, generalised erythema as well. So these are some of the pictures that we saw in Tonga. So this is actually a child who had thickened heart valves, and this is all we saw on the skin. So it can be very subtle, just a couple of papules. And I think just from zooming out now, Lucha's study in Fiji, I think for me, shows that mass treatment is better than symptomatic treatment. So even if you just compare the two permethrin arms, which suggests to me that even if you're very good, and I don't doubt that the Australians are very good at picking scabies, they still don't see it all, and they actually do better when they treat the whole population than just a small proportion of it, the ones that you identified. So I thought I really need to get some objective evidence for scabies diagnosis, particularly in a setting where there's a lower prevalence and there's uncertainty about the diagnosis. Other clinicians are diagnosing with other conditions. I don't think that's such a big issue in the Pacific, but I think PCR is useful if you can get access to it. Just as an illustration, one case that we dealt with had generalised eczema with focal ulcers, crusting, and we treated with permethrin. Permethrin sometimes is used almost as a diagnostic tool where the response to permethrin can be dramatic. But sometimes you get a flare and actually the skin gets temporarily worse after permethrin treatment. Generally you don't want to treat infected skin with permethrin. And so we were criticised by the GP, and actually the PCR came back a month or so later and said actually this kid's got scabies. They were treating for eczema. I've already mentioned our Auckland study where we saw a lot of topical skin treatment, a lot of antipruritics, so calamine lotion for example, antihistamine cream, emollient, steroid, and many of those cases came back after Cello had analysed samples as PCR positive for scabies. So suggesting that the diagnosis is incorrect quite frequently. So just to summarise some of my thoughts, hunting for burrows and mites misses probably more than 90% of scabies. It's not sensitive. I think checking the IACS criteria is very important. Lucha's going to talk in more detail about that. Papules are the main thing to look for. Crops of papules in a typical distribution. That's extremities, hands, feet. Inaccuracies with the diagnosis translate to major problems with the prevalence, of course. If I'd asked the dermatologist, as I did, is there any scabies in South Auckland, he'd say no, because he was missing it. So that's why I'm quite picky about the diagnosis when I design my studies, or our studies. And I think that's also muddied the association between scabies and rheumatic fever, because if you don't get the scabies right, you're not going to get the association between scabies and rheumatic fever. It's routinely mistaken for other disorders, insect bites, eczema, treatment with steroids. I'm really talking about the Auckland experience here, where there's a lot of, comparatively, a lot more access to medical treatment. An objective method such as qPCR, I think, is very desirable, and hopefully Cello will illuminate that side of things a little bit more for you. But so this is just highlighting some of the learnings that I've had over the years that I've been looking at scabies, and hopefully that'll help you on your journey with improving the recognition. And Cello and Lucia will illuminate the situation a little bit more for you. So thank you.